session here. I would like to invite the moderator of the session, Dr. Divakant Mishra sir. A very warm welcome, sir.
Thank you so much.
Sir, I would like you to now invite chairman, co-chairman, and the conveyor. Over to you, sir.
Right. Thank you so much, and we welcome you to another YOSI session, which is the second YOSI session, and it's trials in residency versus trials.
मैं कॉल करता हूँ, मैं अभी कॉन्फ्रेंस में हूँ, half an hour कॉल करता हूँ.
Please mute yourself. Yeah. So trial in residency versus trial in real life. So I have the great honor to welcome our chair, co-chair, Dr. Digvijay Singh, who is the president of the Young Ophthalmologist Society of India and heads the Noble Eye Care Center in Gurgaon, and Dr. Sonal Kalia, who is the vice president of Young Ophthalmologist Society of India and an assistant professor at the SMS Medical College, Jaipur. And next, I will request Pranesh, who is a medical officer at Arvind Eye Hospital, to briefly introduce all our speakers so that we can start the session.
Thank you, Divakant sir, and welcome to this session on trials in residency versus trials in real life. So we have around 7 speakers, so 10 minutes each. And how many minutes can we have for discussion, sir? Can we have 3 minutes?
Yes, I think we'll decide as per the length of the talk.
Right. Oh. So we can have a short discussion after every talk. So the first speaker, Dr. Anupam Singh, is a first-year resident from RIO Sitapur, and it's very refreshing to see a resident here giving us a talk, giving us his perspective on the impact of pandemic on his training as a first-year resident. So over to Dr. Anupam.
Good morning, sir.
Can we have a time up for 10 minutes?
Yes, you're audible. Please go ahead.
So is my screen visible, sir?
Yes, please go ahead.
Do we need a timer, sir, for 10 minutes? Can we have one?
Yes, sir.
Yes, sir. We are on it, sir. We are on it.
Okay, thank you.
Okay, sir.
Please carry on, Anupam.
Okay. Good morning, everyone. Myself, Dr. Anupam Singh. I am going to talk on the impact of the COVID-19 pandemic on my training as a first-year resident in ophthalmology. I am here to talk about my journey as a first-year resident in these hard COVID times. As we all know, at the dusk of the year 2019, COVID-19 emerges as a new threat to the medical fraternity worldwide. And as a frontline worker, we resident felt its impact at its worst. And after being in this pandemic for a long duration of 1.5 years, we all felt burnout and stress. This is the topic of the global concern that how we can restructure the residency program in the view of the threat imposed by the COVID-19 on our medical fraternity. There are many studies done in India as well as the worldwide that how we can change the structure of our residency program and how we can improve with that. Now, starting with my journey, at the dawn of the new decade, in the year of 2020, heralded an inauspicious occasion for the ophthalmologist as the global outbreak of the SARS-CoV-2 virus occurred. In the year 2020, it was marked by the great challenge in the form of the COVID-19 pandemic. And on the 99th day of the nationwide lockdown, and with the burden of the 4 lakh cases, we joined our residency program. But due to the COVID protocol, instead of the orientation, we have been sent to the 14 days of the quarantine. Then, after finishing these 14 days of the quarantine, we were introduced to the branch, the duty cycle, and the responsibilities with the stricter trials protocols. So instead of the physical instruction, the whole ritual was being performed on the Cisco WebEx, which later became our Lord and the Saviors for our academic activities. We then came to know how COVID-19 has crippled the routine activities of the hospital, and the huge number of the patient, which at the time could get overwhelming, was reduced to very low numbers. At the time of the orientation, the teaching on the online platform has become the new normal. So instead of the one-on-one bedside teaching and the rounds and the physical teachings, we were then shifted to be on the online platform like the WebEx and the Zoom. And after that, we were taught about the COVID-19 protocols, in which the hand hygiene, which becomes the insignificant in the mind of the people from a very long time, which had lost in importance, become extremely important. and social distancing becomes must. But in ophthalmology, how we can cope with the social distancing, how we can go without the examination? Then the sanitization of the every instrument after the use become routine, and it is mandatory to use the mask all the time. Sometimes we have to use even 2 masks in the case of the community services and the camp, even if it is what it was very suffocating. Then we have to use the protective equipment and shields as per the risk level after the trials. And then we have to provide all the equipment that have the chin or head width with the best shield. So after the orientation with the OPD and the OT services, we were introduced to the backbone of the ophthalmology, which is known as the community. The community halls, which were once filled with the patient who don't know about the social distancing and the mask, are now empty and having very few patients. Here we can see that the huge load of the patient in the community halls before the COVID era, and in the second image we can see that how very few patients are there in the community halls. The outreach programs also become the non-functional, and even if planned to go somewhere in the camps, there too we have very few patients, and we have to wear the full PPE kit in the hot and the humid environment. It becomes really cumbersome to work like this in the field, wearing the full kit. And before the COVID-19, at our center, we used to perform around 400 surgeries in a day. But after the outbreak, all the elective surgeries were halted, and emergency services are done only when it was very necessary. All the OT complexes were empty, waiting for the patient, and it became really hard for us to learn, and it really broke our learning curve as a resident. In the meantime, we were introduced to the wet lab. It really worked as a boon for us, and we used to practice on the goat eye, bananas, and the thermocol. It really helped us to shape our skills in the hard times without having the full exposure to the surgery. In this image, we can see that we can do suture on the thermocol, banana. We can use the goat eye, and we can also use the unfit donor cornea for the donor cornea in the wet lab for the practice of the phacoemulsification and the keratoplasty. And in the image G and H, we can see how we can fix the goat eye on the set lamp and use it to practice for the indentation tonometry. And after that, we move to the different diagnostic technique. Then also we try to acquire the new diagnostic technique in the meantime. Then with the decrease in the number of the cases, the normalcy has returned. And after that, we started to organize camp for the needy people. But in the absence of the proper treatment and care during the COVID times, our burden have increased in the multiple folds. In the meantime, because the government of India launches the initiative to immunize the frontline workers, and it really helped a lot us in restoring the full-fledged OPD and the community services. As we were returning to the normal routine services, the rise of the second wave was imminent, and after the mid-Feb, the number of cases is starting to rise, and then in the month of the March, the second wave arrived. We were again went into the partial lockdown, and the OPD services and surgeries were restricted. And then within a period of the week or two, the total complete lockdown was imposed in our state, forcing us to de-escalate to the emergency services only. That means no OT, no OPD, and no hands-on. It again sent us to the wet lab, where we sharpen our skill more. This time we came prepared, and here in this image we can see that image A is preparing the eye stand plus eyeball stand with the fixation head with or without the goat side, and the image B is the mask to practice eye fixation head. This time in the wet lab we started to practice for the phaco. In image C, in image D, we can see how we can use the instruments which are shown in the image B and C. We also move on the online resources for our academics, and this time we were vigilant, so we started to prepare for the online exam. We started to prepare for the ICU examination as well, and then after that, there was the relaxation in the criteria of lockdown happened, and we resume our services at the half capacity with the fear of the new variants, and all the necessary precautions were taken in these also. Now at the present time, we are at the brink of the third wave, and we must adhere to the COVID protocol strictly for our as well as the patient safety. To summarize, The outbreak of the COVID-19 prolonged our learning curve as an ophthalmologist, and in the absence of the patient in the circle hand-on, one may opt for the online resources for the study as well as the online resource for the study as well as online classes, and we may also shift to the wet lab to hone over our skills. But it only causes a small increment in our skill set. And in this pandemic affect our residency program very badly, and we must think to restructure it for the harder times. Thank you, sir.
So thank you, Dr. Anupam. It was very inspiring to see these valiant efforts to learn despite these testing times. So Divakant sir, any thoughts on that?
Yeah, great. And it was really nice to see how well you have utilized the time and with the wet lab and everything. So how was your experience with the wet lab? Do you think it is of course, we will be having subsequent talks on that, but what was your personal experience with the wet lab?
Sir, in the absence of the proper hands-on, wet labs are very useful. And we used to prepare them. Then after that, we used to do the surgeries. And these COVID times, sir, we were not getting proper hands-on. So, sir, it's helped us a lot, sir.
When you resumed your routine surgical cases, your training program, so did you think that the deficiency that was because of the lack of cases, was it in some way covered by the wet lab experience that you had?
Yes, sir, it was covered by a wet lab, but sir, it was not as efficient as the normal cases, sir, or normal hands-on, sir.
Great. Pranesh, any other comments from the panelists?
Hi. So congratulations, Dr. Anupam, on your excellent presentation.
Thank you,
I wanted to ask you something, like you have attended offline lectures obviously before in your MBBS. So
Yes.
What are your opinion about, online versus the offline format? What are the difficulties you face or the advantages thereof?
Ma'am, in offline format, the interaction is very good. The one-on-one interaction were very good. And we were used to concentrate more because the presenter was in front of us and we were to interact more. But ma'am, it is not much possible in the online form, ma'am. And there are much distraction in the online form. And the screen time is more. And some of us are not used to for that much prolonged screen time, ma'am.
Okay, but some of my residents have felt that the online format is really great because they get to attend it from the comfort of their home, and it's like more informal. So it's sort of a more relaxing an environment. But then yes, your points are valid as well. It's a to each his own kind of a situation. But we have to make most of what we have. So
Yes, ma'am.
Once again, congratulations on your excellent presentation.
Thank you, ma'am.
Anupam, do you sleep often during online classes?
Sir, it do happen, sir. We feel tired and we feel bored. And sir, there are too much distractions also. So, sir, that's why, sir, I prefer the offline classes more, sir.
And thank you for that honest answer.
I think even the concept of kind of group learning or peer-to-peer learning together is different in an offline mode. Online, you do tend to lose that. You can't really discuss the way things normally were discussed.
Sir, that human touch works like some magic, sir.
Pranesh, let's move on to the next topic.
Thank you, sir.
Thank you, Anupam. And next we have Dr. Amar Pujari, Assistant Professor from RP Center, AIIMS. Sir is an imaging innovator, and he is going to shed some light on the innovative approaches in wet lab training for residents. I think we can relate a lot to Anupam's presentation. So over to you, sir.
Thank you, Dr. Pranesh. And good morning, Digvijay sir. Hi, Dr. Divakant. Hi, Dr. Pranesh, and everybody. So is my slide visible?
Yes.
Yes.
Okay, thank you. So I do not have any financial interest, but previous presentation, Dr. Anupam's presentation, whatever was there, his concerns were genuine and they need to be addressed. So being one of the highest loaded residency training program we have at RP Center, so we have around 110 junior residents and around 60 senior residents. So these people were not getting proper hands-on training because patients were not there. Of course, theoretical teaching is going on since almost more than 1 year, since almost you can say 15, 16 months. but they can read the theoretical things, but the surgical touch, the hand-eye coordination, the memory you are going to get with your hand during surgeries, that is of immense importance, because if you are not able to gather that during your residency, so the whole life is going to be kind of tough. So to address this one, as we know, in ophthalmology, microsurgical training is vital, right? So it needs to be told in a systematic manner. And as Dr. Anupam rightly said, it's a one-to-one human interaction. That human touch needs to be there, right? But in recent COVID times, we know that this has hampered very severely. We cannot be with our close friends, right? So we need to take proper social distancing. So during that one, theoretical teaching continued, as many people said, through webinars and other things. But practically, our surgical training is quite important in ophthalmology. So to address these issues, many publications, many guidelines were appeared in various national and international journals. We are all aware. Almost since 1 year, many journals are publishing only COVID-related articles. But ultimately, when it comes to individual level, we need to address what is exactly happening to a particular resident, how he is feeling. Because one thing is social distancing, and we can teach the theoretical things to lab, but we need to tell them the surgical things, because that will make them more interactive. They should then get the idea that no, we don't. You would need to do ophthalmology. Ophthalmology is interesting. They should get that interesting nature or the interesting thought. So that is this thing. So to address this one, we have many residents. They were coming with many complaints. So I tried to explore more ways. So I found a limited number of surgical techniques in the literature. Previously, even though I have described 1 or 2 techniques on GO-TI. So that made me to take major decision so that I can explore more. So I want to tell the same thing here so that other residents can use this one, right? So this is a simple video. I want to say how we can mount the globe while doing different kind of surgeries. The most important thing is to inspect the globe, whether the conjunctival scleral integrity is there or not, how about the ocular tension, right? So if you do this one, then try to identify the anatomical landmarks, like this is equator and this is limbus, right? So then corneal integrity, you can check whether cornea is clear or not. Anterior chamber do not have many pigments, so then only can do cataract surgery. So after that one, fixing it to a mannequin head, that is quite important. So we are going to describe so many surgeries. So for corneal, cataract, and iris related surgeries, we can say that we can wrap the globe in an upright position like this. So we are going to wrap the swab around the equator, right? So there should be visible cornea and some part of the anterior sclera. So this is for anterior segment surgeries, right? So if you want to do some other surgeries like glaucoma surgeries and any kind of scleral based or limbal based procedures, so in that case, you need to wrap in a slightly slanted position like this, where you are going to infiltrate, touch the limbus, but superiorly you are going to go beyond slightly the equator. So around 10 to 15 millimeter the antisclera is visible, where you can do a proper trabeculectomy flap or any other kind of perforation repair you can do by putting the eye in a slanted position. The third position was when you want to do some other procedure like extraocular muscle surgery, that is squint procedures. You can find extraocular muscles in GO-TI. Many people were surprised, how can we find? But the thing is, like, you need to say the local slaughter people that we need more of extraocular residual tissue around the globe. They are going to take out only the globe, but you can say that we need more extraocular tissue to try to dissect. We will dissect that one. So in that case, you can order the globes. So like this, you can explore the extraocular muscle and you can wrap in such a way that half of the cornea and till the posterior optic nerve, that is wrapped, and remaining portion is exposed, that is rectus muscle insertion. So how to mount these globes once you are wrapped inside the cotton this thing? So you can put the globe for anti-segment surgeries like this. So then you can rotate either horizontally or vertically, right? Similarly for TRAB and other glaucoma related procedures, so you can slightly take a slanted position like this. And for extraocular muscle surgeries, again, you can use this one, but you need to do more slanting and you need to take out the rectus muscle. So once you take out the rectus muscle, you need to pass a suture along the free end so that you can simulate the resting tension within the recti muscle. So then you can do various surgeries. So I will describe one by one. So these are extraocular muscle surgery techniques. So as we know, basically strabismus has only simple surgeries, but it's planning that is going to require your real knack. So but you can teach the residents so that they can enjoy the surgeries. So similarly, as I said in the previous video, we explored the rectus muscle resection and we told them, and since 3 years, our residents are routinely practicing rectus muscle resection, dissection, and plication surgery. So this is how you can do resection as well. You can mark a certain distance on the recti muscles and you can get take out the or you can resect the muscle and you can resuture back the muscle onto the sclera. So similarly, you can do plication. This is described by Professor Pradeep Sharma, where it is called as reinforced plication. It was his technique. So that also we are teaching our residents at our RP center. So similarly, cataract and IOL surgery are quite famous. As you know, phaco and ECC has been frequently taught. But at the same time, nobody has thought about how to put the IOL in the bag, in the sulcus and antechamber. Here you can see in this eye, we deliberately induced posterior capsular rent, and we told them how to do vitrectomy. So make sure that pupil is regular, and we made him to put him or her in the an ACIOL so that they can practice and they can implant as well as they can explant the antechamber IOLs as well as sulcus and bag based IOLs. So then they need to maintain the proper suture practices so that ultimately everything till the wound closure is simulated properly. So similarly, some of the anti-segment enthusiasts, they approached me, they said, sir, we want to do SFL, but if you look into the horizontal diameter of the goat's eye, that has around 14 to 15 millimeter. Compared to human eyes, it's quite large. So single multi-piece IOL won't be able to fix that one. So in that, what I did is like I took another haptic of another multi-piece IOL. So I sutured them so that we can increase the length of the haptic. So some of the anti-segment surgeons, 3 to 4 surgeons, SRs, so they were able to create flaps and they were able to insert this IOL along the scleral flaps. So similarly, ICL was also simulated by taking a dummy ICL or a square-edged IOL, right? So in corneal surgeries, majority of the surgeons, students, they learn that how to create a stromal dissection so that they can paint it. They can do a corneal tattooing by simply putting the Tefan blue dye. So similarly, anterolamellar keratoplasty can be done by judged dissection using crescent blade or even scissors. Right. So similarly, this is also routinely being described, that is full thickness keratoplate, just to refine their surgical skills where they can put proper radial corneal sutures. So glaucoma wise, we told them how to do a systematic conjunctival peritomy and stepwise scleral dissection. They can make out a thin flap or even thick flap. Then how to create osteotomy and how to make sure that you have placed the you have sutured the scleral flap properly. Some of the people were even practiced how to put releasable sutures and how to release them. They also told that. And some people came with extruded or used AGV wall. So we told that we can put this beneath the conjunctival tenons and you can make a proper antechamber entry and you can have an experience of how to put AGV in GOTA as well. So trauma injuries are more common. We get at least 4 to 5 injuries every day at our center. So it's quite important that the resident at first or second semester must learn how to repair corneal injuries, even scleral injury. So we systematically simulated even simple injuries. This is an example of simple injury, complex injuries, only scleral injuries extending beyond the muscle, tri-radiate perforation, everything we were able to simulate, even the lenticular injuries, lens aspiration. So some people practice even pupilloplasty. They used 90 Prolene, and as we know, the GO-type pupil is oval rather than circular. So you can close one portion and you can simulate single pass 4-through pupilloplasty. And similarly, manually we induced iridodialysis. On one part, you can see here, we have induced a dialysis. So we try to repair the dialysis using the same Prolene suture, right? So for corneal and ocular surface, pterygium, as we know, probably every resident has done during his first year residency. First surgery, they will get his pterygium. So it was like dissecting the conjunctiva in a graded manner. That was important. So many people did pterygium dissection on the same eye in many aspects, right? So dissected corneal buttons, some anti-segment surgeon used just to peel them so that they wanted to prepare a DMEC roll. And we have national eye bank, so people who are going to retrieve the eyes, so they must be taught how to take out the eye tissue and how to separate the evil tissue, how to have a proper scleral rim. So oculoplasty wise and retina wise, we have lesser techniques. So this is buckling technique, where we can take out 4 individual recti muscles from different eyes and we can suture the recti muscles and we can tell them how to put the buckling sutures, band, as well as even ethibond sutures, how to tie the final implant. So we do not have eyelids, because if you want to bring the goat head, that needs a drastic modification in our like ophthalmic wet lab. So what we did is we told them how to do evisceration. That is one of the procedure we perform, how to put implant and how to put secondary sutures. So this is a poster I have made and we have pasted it in our national skill development lab, so that every SR, whoever is doing glaucoma, retina, they can come here and whatever the thing we have described, they can practice and they can innovate even more. So we enumerated all the techniques in the literature. So goat eye, rabbit eye, human eyes, we made tables, and we were able to publish this as a major review, so that we included another 50-55 studies from the literature, and we told around 20 new techniques. So we made a large compilation of this one, so that everyone across the globe can practice these kind of techniques during this COVID lockdown. Thank you.
Thanks a lot, Amar sir. It was very refreshing to see other surgeries also being performed apart from non-cataract. So I have a question. Most often the difficulty what we faced was the soft eyeballs in goats. So is there any way to circumvent that problem? Because only if the eyeballs are tense enough, we can perform whatever procedure we wish to.
Yes. The one thing is, like as I showed, you can wrap the globe. So the thing is, like what you need to do is you try to squeeze on the posterior aspect, then try to put the gauze, so that either by titrating the gauze piece, you can put more pressure. You can create more pressure in the antechamber. So that is one thing. Or else you can inject some viscoelastic in the vitreous cavity so that the eye is going to balloon up. So that you can do. But routinely we are going to tighten the eye from the posterior aspect, because that will stabilize the globe in the mannequin head, as well as that is going to increase your IOP. That's what we do.
Right. What if we don't have a mannequin head? Is there any other way to fix?
No, I'm sorry, we are fortunate enough to have mannequin head, but I feel we can spend around 500 or 1,000 bucks and get even our own mannequin head, because that is the best, because that is going to give your nasal contour, brow contour, everything, because everything you are going to feel that it's a human eye, except eyelids. Majority of the things, even you can create a deep seated eye scenario, you can make out a more myopic eye scenario. So it is better, we can spend some amount of that one, some price, some money on that one, and can buy a mannequin head. That will be better rather than going for some other plain thing where you are going to put an eyeball. So that will not simulate any human this thing.
Right. Thank you, sir. Divakant, you want to add anything?
Yes, Dr. Amar, any experience with those artificial eyes that were available?
We have, Dr. Namrata has brought some of the artificial corneas, and Dr. Gunjan and other people are planning, they are taking ping pong balls, those are rubber balls. So where they are creating a crater, so that the crater will be around 10 millimeters. So in that one, they are going to put some dough, so that will simulate as your nucleus, and they are putting the artificial cornea, then they are doing the cataract surgery. Now, artificial cornea we have, rest of the artificial eye we do not have. We mainly rely on goat eye.
So another quick question, Amar. So we have the surgical training center at RP Center that I think you would have used, and you're also probably directing now.
Yes.
And as residents, all of us have gone through initial wet lab before we moved into surgery. So how easy is it for outside people to access that surgical training center? And what difference did you find between what you did there versus the real life? Obviously, there's a difference, but your
Yes, sir. Yes, sir. Definitely. As I said, it's mainly Tushar sir and Dr. Titya who are heading the lab, sir. So whatever I did, I had these ideas and I went to those people and I told them these are the things we can explore. They gave me green signals. So last time in some of the YOSI webinars, some people asked Dr. Tushar also how we can access the National Skill Development Lab, sir. So he said you can give her this thing and you can mail me so that he will prepare a timetable and you can access our national lab also, sir. So that is one way they can come inside our lab. But if you ask me how another common person can do this one outside, sir. So in that case, you can purchase a mannequin head, and goat size are available for 20 or 30 rupees, sir. Every city has a goat slaughterhouse, sir. So can demand them. If you give 20 or 40 rupees, you can get good number of eyes, sir. Even for 100 rupees, you will get five eyes. So you can practice on those. It's very cheap, sir. So I mean to say.
Right. Thanks.
Yes, sir.
And YOSI, actually, I hope YOSI members can also get in touch with you.
Yes, sir. Sure, sir. I can be of any help, sir. Whatever you say. Yes.
Okay. Thanks.
Okay. Thank you, sir.
So any other comments from panelists? If not, we'll go to the next topic. Dr. Gunjan Buddhiraja ma'am is here. She has numerous publications in national and international journals. Her interests include refractive surgeries and corneal procedures. She will present on a more relevant topic, webinars, what's in it for the young ophthalmologists. So over to you, ma'am.
Screen visible?
Screen is visible, but the voice is breaking.
Hello.
Still, the voice is not very clear.
Network issue,
Gunjan, I feel you are having a connectivity error.
Put it in slideshow mode. Put it in slideshow mode. कनेक्टिविटी प्रॉब्लम है, स्लाइड शो हो रखा है, आ नहीं रहा है.
Maybe you can check your connection, and in the meantime, you can have the next talk.
Okay.
Hello.
Okay. So
तो ये दिक्कत देगा आपको बार-बार, आपको नेटवर्क नहीं है ये.
okay. So till then we'll go to the next topic. So Dr. Akshay Nair specializes in oculoplasty surgery and ocular oncology. He has a numerous publications and books written under his belt, and he owns a vast social media following, and he is a popular figure himself. So sir will give his journey on how to achieve a social media following.
I think Gunjan needs to stop her screen share and allow me to share.
Can the technical team do that? Stop the share for Dr.
रणबीर जी हेल्प कर दो.
सर जब तक ये मैं भी यहाँ से रिमूव कर रहा हूँ, हो नहीं पा रहे हो.
अच्छा हो गया.
अच्छा हो गया, चलो. Okay, so I hope my screen is visible now.
Yes sir, it is.
Excellent. So basically, I'll be talking about social media presence and how is it needed for an ophthalmologist or for all of us. And lots of it is based on my experience in the past 9 years as in private practice. The first thing is why have an online presence? At the end of the day, we need to understand we are service providers on some level, even though and healthcare itself is a large service sector. We have an online marketplace for everything, and so therefore, even this conference is now online. There is going to be a time where the old school way of referral, where a doctor refers the patients to you or a general practitioner, may not happen. And in the near future, every patient is going to diagnose themselves, which they already are doing, and eventually look for a doctor and refer themselves online. So that is one reason why to have an online presence. Also, you need to let people know, have basic information about yourself, your practice setting, your specialty. Your colleagues and peers need to know. Also, social media can be useful if you can showcase what you're doing, if it's a new equipment, something unusual, and some achievements as well. So it's needed, an online presence is needed, and the first thing you should have is your own website if you're in private practice or even being in a part of a group practice or a specialty, because your website is your information, your way, in your narrative, without any patient saying something, anybody else saying something. So there are no restrictions. You should remember that you should not get too technical on your website. It's mainly for patients and it's not for doctors. So put yourself in a patient's place and try to see how your website should come across. It should be user-friendly, accessible on a mobile. 75% of the people who access my website access it from the mobile. So it has to be customized and optimized for a mobile phone viewing. And having a website is not enough. You have to have ways that they can contact you either by email or to another social media link or Instagram or phone number and respond to people getting to you. How do you go about it? The first thing is to register your domain. Your domain is what is xyz.com, whatever your name or your hospital name. Buy the domain, go to a hosting site which can host it. Hosting websites are places that will store your domain and your website, and people access that host to see your website. Then gradually you build content and site. For me, I bought my domain 10 years ago, but until 4 years ago, I didn't even start making on my website. And it was a mental block for me, or an inertia. And you need to overcome that, because eventually you will realize that current tools on website builders that allow you to build a website and different pages is almost like a PowerPoint presentation. You can copy paste things, write things, animate, put in a video like you're making a slide. And the website builders that these hosting sites offer are very user friendly and can translate into a good website. If you have the ways and means, by all means, get a web designer, and then someone who can also do a search engine optimization for you as well. The next thing is Facebook. It is a necessary evil in our lives. But a few things that you need to know is that the average age of the Facebook user is about 40 years in India. So, and also there is limited reach, because any Facebook page of yours or a post of yours can be seen only by your friends. And you need to change the visibility settings for it to be visible to public. And once you have a public profile, that is wading into dangerous territory, because then you're open to anybody and everybody, and also open to criticism, abuse, and a lot of other things. You can have a separate personal and professional page. And on your professional page, you can even pay for promotional content or pushed ads that get focused on people who are looking for keywords that match with your profile. Beware of what I call the academic feast, because after every conference, people will post on their Facebook, had a wonderful academic feast on this Saturday at this website. So at this conference. So try not to do a lot of self-promotion on Facebook. Caution, first thing is consent is king. No patient photographs or patient cases to be discussed on Facebook and social media without the patient's consent. Stay away from arguments. 3 things you should not be discussing on Facebook as a professional: politics, cricket, and Bollywood. And also there are Facebook guidelines. If you post a before and after or a cosmetic photo, their algorithm picks it up and says this is zooming into a very body specific part. It portrays certain before and after results. That doesn't work with us. So it's you have to play by the rules there. The next is Instagram. This is the most underrated marketing tool that ophthalmologists have. It's a photograph based app. All of us use Instagram. You can have multiple accounts on your same app in the phone. So one can be a personal, one can be a completely professional, and here they don't even need to be linked like Facebook. They can be completely different. The key is to use the right hashtags or the keywords. Now, say for example, look up LASIK. Half the photos have got nothing to do with LASIK, but yet they show up, and these are the top posts. These are the posts that people have looked up, liked, and interacted with, which automatically pushes them up in the algorithm when people search for it. You can be an influencer even on Instagram as a healthcare professional. Look at cataract surgery. Again, half of them are cataract related, half of them are not. So you need to use the right hash keywords. People search hashtags. People search for specific hashtags. People follow them. So when you post something related or connected to that, that comes up in the top of their feed through the Instagram algorithm. Unlike Facebook, the average age of the active Instagram user is 23. So you can customize content based on what app you're using. Say, for example, this is Dagny Zhu, who is a cataract surgeon based in California, cataract refractive surgeon. Look at her number of followers because she's creating interactive posts. People combine their personal interests as well as their professional interests and have a public account. This is again a cataract surgeon based in the US, but he's a fitness freak. So his profile is entirely about fitness. And again, 28,000 followers. So these makes them very popular. They are key opinion leaders and can change things and opinions and get a lot of patients through their profiles. If used well, patient generation can be very high, and it can even be better if you're able to merge platforms like Instagram connected to your Facebook account. The next is YouTube. Now, YouTube can be used for multiple things. It can be a surgical, and I think Pranesh has been the best example of that, of how he's harnessed the power of YouTube to create such amazing detailed examination videos aimed at residents, at teaching. And the key is high quality, relevant content, which has to be frequently posted. If you post 1 or 2 good videos and leave it, then that won't go up. YouTube search algorithm is very specific. The more views your videos get, the more automatically it gets pushed up when people search for similar keywords. You can have surgical videos like Dr. Pradeep Mohanta, who look, you can see 16,000 subscribers. The YouTube videos, patients actually see them. They are seen as validation. It's the ultimate external audit. You're showing your videos to the whole world, so everybody knows what it can be done. You can monetize it, but that's not something you should be looking for. Also, patients can come in. You can have a hospital tour in your YouTube website. It is a means to communicate directly to the patient, and patients are very tech savvy now. They're not afraid to see blood, so they actually see videos. Sometimes you have the obscure thing, like I got this a couple of days ago. I want a tentative cost of filler. I saw a number on YouTube. This is the cost of the filler box. How much would you charge if I bring my own filler? So you have some weird things. It's like telling, I'll bring my own Avastin. How much will you charge to inject? So, you have to take the good with the bad. My experience is that I wrestled with the idea of having my own website because I said, I'm a doctor. Like I said, there's so much inertia for a long time. I built my own website. I haven't paid for paid promotions yet. I have Instagram for a few years and YouTube for a few years. Facebook, I keep professional use to a minimal. I find Facebook very jarring. It doesn't keep me in a good mind space, so I keep Facebook out. On through my website, there is a very very optimized, phone version also of it, which has to be used well. And thankfully for me, Oculoplasty is a very visual brand. So before and after photos, especially of Indian patients, is a very good deal maker for patients who see similar conditions and know that they should get it. I have a contact me page through which I answer emails regularly. On an average, I get about 20 queries a week, which translates to 3 to 4 appointments a week, and eventually 3 to 4 surgeries a month, which surprisingly is very organic. So I don't have to go looking for this. These things are coming directly, so it's great. Similarly with Instagram, you have to have a personal connect and respond to it. People try to get consults. You have to be a little patient and give it some time. Both of these are patients whose consents I have taken and posted this and actually got operated by me. But you have to, the flip side is you get a lot of frivolous inquiries. So you have to, patients who are not serious but just will put in an inquiry. Again, this is translating to 4 to 5 procedures a month. And same is the case for YouTube. YouTube, I use it as an awareness channel. We post awareness videos, interviews or patient education videos. I have about 4,000 subscribers. It primarily started as a surgical video and a teaching tool, but now we've expanded that. This also generates a lot of patients on their own. It has the widest reach. So you have to, we take more time out for YouTube. So to summarize, you have to start early and you have to have a multi-pronged approach on social media, target all different social media channels, be consistent in content generation, keep it high quality. Remember, there's going to be an incubation period. You have a blog or a website or in social media, the first 6 months, you may not even hear anything from it, but be consistent with high quality content. It will give you good dividends. 3 things never discuss on social media. You never know, who has what. PPP, pricing, giving out a prescription, and patient pictures, especially those of other patients. Never share on social media. Consent is king. Unless you have written consent from a patient about their, posting their content or photos, never do it. Paid promotion is a gray area, which, each one has to decide about their own ethics. And that is it from me. I'm sorry, I'm a minute over time.
Thank you so much, sir. You have given us a short masterclass on how to build a strong online presence or branding. So I have a question. So what is the cost to build a website? A minimum cost?
So minimum cost. So if you were to host your own website, but hosting fees are as low as 1,700 rupees a month, a year, or even if you, depending on the amount of storage that you need for your website, you can get that for even lesser for 5-year period. And once you have your domain, once you bought your domain, you need to keep renewing your hosting. Hosting is not that expensive. Recently, I renewed my hosting, but it was about 4,000 rupees for 3 years. And a good website designer can do a job, over about 20 pages in the website for about 20 to 25,000. So a total bunch of say 45,000 can get you a good website designer who will create your pages and hosting for 3 to 5 years. And at the end of the day, if a good website is generating even 2 or 3 cases, it's paying for itself.
Thank you, sir. So Divakant, sir, you have any comments?
So one thing, Dr. Akshay, I think another thing important is to get yourself listed on Google Business. So I think I am getting almost 2 to 3 pages in my Google listings. And if you frame that properly and your name comes up within the first top 3 or 4 people, so patients tend to prefer that. My question to you is, now the social media platforms, you see a lot of patients searching on the social media platforms as well. So whether it is prudent to invest on a website or to invest on promotions if you have just one option, to invest on promotions on social media or to get a website for yourself?
I would definitely recommend a website, because you have absolute control over what content is being put there and what people can see, and they will see exactly what you want them to see. Facebook has a lot of personal interactions, your family photos, your vacation photos. Even if there's a professional page, you need to link it to a personal page. Then you need to keep that private and things like that. So I find that to be very cumbersome. So, like I said, a website is yours with complete control and access over it. So,
Any more comments from the panelists?
I think well presented overall.
okay, thank you.
Thank you, Abhishek, sir.
The next one.
Yeah. So is Gunjan ma'am ready now? Or can
Yeah.
Great.
My screen is visible to all?
Yes.
Okay. So probably I'll switch off my video because I think the network is not very stable. Good morning, one and all. And the topic for today is webinars. What's in it for yours? This topic is not new for all of us because since the past year, we have been well acquainted with what webinars are actually. So what's actually a webinar? It's an amalgamation of the two words, which is web and the seminar. And the things which we need is a stable internet connection, any device which is compatible, and different platforms where we can attend these webinars on. So over the past year, there have been millions of webinars that are being hosted on different platforms. One is on All India Ophthalmological Society platform. Then there are iFocus online lectures available. There are also YOSI webinars, which are being conducted every month. And there are all the lectures that are present on cyber side. They have now also come up with webinars. There are academic clinical webinars as well that have been present since over last 1.5 years. So it's almost like a cheese platter where we have a lot of things to choose from a big platter. And one and again, we can have all the variety of webinars on different topics. Some topics are really innovative over the year, which we have seen, which were not there in the physical conferences before. So it comes down to one thing, that what exactly are the pros and the cons of these webinars, because there have been a lot of debates whether people prefer virtual webinars over physical webinars. So let's see what actually can be the pros. Definitely they have posed as motivation during those challenging times. We all agree, because in the beginning of the lockdowns last year, we were not sure what we are dealing with. And as for me as well, I was in the mid of my fellowship period, and I was not sure whether I'll be able to learn more on academic purposes. So we had a lot of virtual classes, which actually made me go back to the textbooks and read them very well. So one thing is that you can learn at your own pace, because sometimes in the physical conferences, sometimes you're rushing, you're traveling, or sometimes you're just too much lectures in different halls which you are not able to cope up. So in this, we have an option of webinars that are present on YouTube or Facebook Live, that we can go back and see them at our own pace as well. But another thing is that they expose us to different faculties of different places in different universities and countries, and a lot of people which we are not, we have not been exposed before. So cons can be, yes, of course, we do not have any hands-on when we are seeing these webinars. There is no skill development in case of hands-on, but definitely video-assisted surgical training can be helpful. Sometimes there's too much information that is available, and we're not able to understand that whether this information will be grasped in and absorbed into our heads. So I just conducted a survey internally as well as on various public platforms to understand what people have what people hold the views about these webinars, and especially the category was of young ophthalmologists. So I asked them a question, that as compared to physical conferences, do you think that virtual platforms are better? And I saw an inclination of people towards the virtual webinars. Also, I had asked one question, whether it's contributing to learning. So again, I saw that there was a slight inclination towards the positive response that yes, they felt that it is contributing to their learning in the period. I had also asked people that what aspects of these webinars they found useful or valuable. So a lot of people answered that questions and answers with the speakers, and the queries they have, if they are answered, are more helpful to them. And case presentations as well as video assisted skill transfers were found to be very much useful to the people. Then I had asked about the suggestions. So people said that definitely physical webinars are better, and webinars they found that it would be more useful if we have option of viewing it later, and shorter and basics were more better for these people, I mean the young ophthalmologists. Some people felt that the advertising of the webinars was not very up to mark, so they were not able to understand and know whether the webinar is going on. Coming on to the conferences as well, we have seen so many conferences being conducted over the virtual platform over the past year, and we are part of one virtual conference as well this year. One positive point in global conferences is that because at the pedestal where young ophthalmologists are as residents or fellows, sometimes it's very difficult to get leaves, and this leads to loss of the training days, and also the stipends and the money they have in their pockets is slightly lesser, so there's a lot of travel expense, and as well as the exposure to international faculty is easier on these platforms. And there's a vast plethora of information that can be gained from the international faculty. Also, we have noted that there has been increased participation over these global conferences over the year because of all these advantages. Although coming on to the cons, definitely there are so many webinars which can cause digital toxicity, the eye strain, and there's a question of attention span that is definitely there, as was discussed in the first talk, that a lot of people are not able to cope up with the webinar content, as well as they are not able to get motivation for a longer period. So Nielsen Norman Group had conducted a survey where they found that a lot of audiences, they hold attention span of 10 seconds in the initial period. So if they do not find the content very interesting in the 10 seconds of their attention, so they do not feel like attending the whole webinars or the web pages. So as I said that there are so many webinars available. Is that possible to attend all of them? I don't think we can attend all of them, and sometimes they are so much confusing that there are some topics which are being conducted at so many platforms. You are attending all of them and you are not sure whether this webinar taught you the right thing or not. So it's definitely better to be selective when you are seeing all these webinars. Definitely, as we come to face-to-face meetings, we have better communication, and as was discussed in the first talk, that personal touches are better. And so many of us agree that these conferences are one of like alumni meet or friends catching up from different places, which is sometimes not possible during the working hours. Of course, we miss the good food that is available on all of these conferences. So the tips can be that we have to be very selective when we are attending the webinars. We should know what topics are we aiming on for attending these webinars. Speakers should also be helpful, as you know, so many speakers from international platforms are also available, and we need to learn a lot of things from these people as well. Also, it's very important that if you are learning or watching a webinar on YouTube or Facebook Live, so it's better to choose any day or a time with when we have a better attention span. Also, a useful thing is to put reminders on your phone. Sometimes we are busy in the work and we do not remember that this is the day and this is the time when a webinar was supposed to be there. So it is always good to put reminders for these webinars so that we do not miss them. So at the end, I will just say it's like a mixed feeling whether physical conferences were better or virtual are better. So one thing we definitely we can ponder upon is that virtual platforms do impart good learning to all of us. So for that, we need to be very selective, as well as the hybrid programs can be created for future, where we have few virtual modules that can be useful, and then we can add on to short-term hands-on training in small batches. We are working on that as well at our hospital. So with that, I will end my talk, and definitely this is a debate which will never stop. So thank you for giving me the opportunity to speak today. Thank you so much.
Thank you, Gunjan ma'am. It was very exhaustive, very interesting talk. You gave us lots of insights into this webinar endemic which is going on along with this pandemic. What I could tell from my experience is that one biggest limiting factor is the duration, the time slot with which these webinars being uploaded. It all often cross 1 hour, 1.5 hours. So from the uploader's perspective, they can divide the topics and they can upload it, like how we do for AIOC.
Yes.
One more tip is that they can put timestamps on the description box. So when we put these timestamps, it is easy for the resident to navigate to which path they want to choose and to watch and to learn from. From the resident's perspective, or from the audience perspective, one easy way to watch these long lectures or webinars is that watch in 2x speed or 1.5x speed. Kind of fastens the time spent or invested in learning. Also, it kind of keeps us attention for a long time. So thanks again, ma'am. Divakant sir, Digvijay Singh sir, any thoughts?
I think she's covered most of the prudent points. Something that we've found practically different in the webinar series has been that we've been able to do a lot of education programs across the country while still sitting in our cities. Like for example, they do the Glaucoma India Education Program as a part of the GSI, Glaucoma Society of India, where two speakers would have to first travel to a particular relatively tier 2 city or tier 1 city and give a talk. Now we could get the best of speakers sitting in there, in the institutes and giving the same talks. So it was a benefit in that sense that it does make life easier. The logistics are also somewhat easier. You could be in two or three places within the same evening, which otherwise, for some of the top speakers you couldn't. But that said, I do miss the fun of the physical meets and the physical conferences and the interaction that you can do there, because that to a major extent has a lot of we realize it now. So we realize the difference now that we've been doing these, that you do miss that one-on-one interactions or those group interactions that used to happen.
Yeah, I agree with Digvijay. A couple of things I think, Pranesh, you also mentioned. Having timestamps is good, especially when they retrospectively load it. Or actually, the first large-scale online conference was WOC last year, where they had a very interesting concept. Every talk had to be pre-recorded and uploaded. That way, every attendant or delegate had to go to their website, could pick the session they wanted to attend, could pick the talk they wanted to hear, and actually move till what part they wanted to hear, what section they wanted to hear. The trouble of having to sit live through the meeting, having to wait for the organizers to upload it later on, all of that was eliminated. Things like having concurrent live sessions was also something that was sorted, because everybody had uploaded their talk and kept it. It was like an online catalog which was open for 4 months. Anytime anyone could go pick and choose what they wanted. And I think that is high quality content curated with time limits. So that is another way that conferences should explore in which they are going.
I also tried one thing which is going to sound a little bit funny, but like we've all been hooked to all sorts of OTT platforms. I've tried to watch some of the longer webinars, like sort of web series, divided it mentally into certain blocks, and then gone on and seeing them, like listening to one talk or two talks in a day, and then moving forward. The recorded ones available, of course. So because sometimes it's also that so much is going on in the other spheres of life that you do not get the time, but you are very much interested in the whole talk. But when one looks at the screen and sees, oh my god, this is like 2.5 hours long, so you can always divide it and see it at your own leisure slowly, instead of just expecting that you will be seeing it one full go. So that is one way that I tried, and I felt that was more useful than seeing all these things at a stretch. Excellent talk, Gunjan.
Thank you so much. We'll move to the next talk. Dr. Sayantan Ghosh did his ophthalmic training from RIO Kolkata, and he has masters in political science and international relations, and international law is his specialization. So we have a very unique niche speaker here with us, and he is going to present on a very intriguing topic, a road to rural, an ophthalmologist's call. So over to you, sir.
A very good morning to the respected seniors and my dear colleagues. Am I visible?
Yes.
Yes.
So my topic is road to rural and ophthalmologist's call. I don't have any financial disclosure. First, why is rural? Why is rural so important? Because 67% of India is rural, according to the population survey we are having. Whereas the doctor population ratio is less than 1 per 20,000, especially the ophthalmologists, as per the NPCB data. And caseload is 10 times more than the urban in rural areas, as per the NFHS data. But our oath asks us to serve the population. So why aren't we rural? There's an apprehension. This torch signifies the rural practice, right? And the slit lamp, vitrectomy, or the subspecialty approaches characterizes the urban approach. So lack of standard instruments, no standard protocol-based treatment, minimalistic lifestyle, poor infra, poor professional and personal growth, all these are our apprehensions. Coming to the hierarchy of the health system, it is actually a pyramidal system with the base formed by the ICAMP. In the private world, it's the ICAMP or school health program in the government services. Then comes the small I hospitals or subdivisional hospitals, medium-sized centers in the district hospital or secondary care hospitals. And the last one, the medical colleges or the corporates. These first two, the ICAMP and the small I hospitals, they actually cater more than 50% of the population in the India. And they have only OPD or a single OT microscope. Village, we have 2.5 lakh villages in the India. And Tier 3 cities are more than 100. But doctors, all the ophthalmologists are actually concentrated in these two centers because they have multiple microscope, they have subspecialty. Tier 2 cities more than 50 cells, Tier 1 is less than 40, almost 40. So we are concentrated here. Competition is more and competition is less in the rural areas. This is a curve taken from the Goldman and Sachet. What do you want? What is our situation after 10 years? What do we dream after 30 years? What do you want? Satiation or satisfaction? How do we scale this satiation or satisfaction? They have given 3 parameters: professional growth, social growth, and personal growth. Now this green line is personal growth. Why is this so important? In the mid-career level, at the 20 years, 10 to 20 years fact, it is very swelling up in the mid-career level. What is personal life? Family completion. Methodically speaking, having 2 children. Ensuring future of next generation. That requires school, colleges, well-being of the dependents. Our parents require state-of-the-art hospital facilities, leisure goals, malls, cinema halls, parks, we require, isn't that? And professional growth, social growth. Now, this personal growth hinders the rural growth of rural migration of the ophthalmologist. Many of the ophthalmologists are from the rural areas. Basically, they're born and brought up there. But they do not prefer to go there because these things hinders them. And social growth, apprehension, appreciation, networking, social standing. In the professional growth, rank from a JC to a medical director, or from an assistant professor to the principal. These are quite possible in rural areas. In fact, this is faster in the rural areas. Let's have a comparison of the different setups: rural, the semi-rural, or the urban. So urban is subspecialty care. Semi-rural is slit lamp, rural is torch. So what do we have in the semi-rural areas? Per surgeon case number is quite high. In fact, we can have equipped subdivisional hospitals, but paying capacity is low. Here, per surgeon case number in the urban areas is quite low, but high paying capacity. So we require more time investment, and the learning curve is slanting and slow. We are coming in the details. This is very important slides. We have an existing healthcare model. What are the existing healthcare models in the for the YOs, young ophthalmologists, in the rural areas? It can be government, it can be private, it can be government and private. So the money matters, isn't that? So in government, monthly salary ranges from the 60K to 1 lakh to start with. In the private, there can be 2 possibilities. It can be an individual setup, entrepreneurship, or it can be an institutional setup where we join as a consultant. Again, the monthly salary is 1 lakh to 1.5 lakhs. But if you start an individual setup, it almost 5 to 10 lakhs to start with. Again, the details follow. Now, this institutional setup can be different. Basically two strata. First is insurance based and second is out of pocket based. We call it from the health administrative perspective. The insurance based is actually NHS, that is the England model. And out of pocket is actually the Finland model. In fact, Finland also doesn't follow that right now. What is for India in insurance based? RSBI, Ayushman Bharat, NPCV, the seasonal bust will be there. In the winter season, there will be huge bust because number of the cataract surgeries will increase. And out of pocket, here there will be a lower income, but it will come on kind of a fixed throughout the year. And we can have a different permutation and combinations of government and private together. This is a very important topic, a rural entrepreneurship. Can we have entrepreneur and doctor at the same sitting? Can the same doctor be an entrepreneur, a successful entrepreneur? Rural areas gives us assured patient load, definitely. Rapid rise in the professional skill. A person does 500 SICS or 500 FECOs and a person does 5,000 FECOs. Definitely the next person will have professional skills. I mean, there will be variations, but it is usually expected. Less corporatization will be there. If you have an individual center, there will be creative independence. There won't be much pressure from the investors. Early capital building will be there. What is this capital? It can be monetary capital. It can be human resource capital. Do we have credit for rural entrepreneurship? Definitely we have. Mudra scheme is there. MSME loans are there. Cost to land is low. Cheaper manpower is there. And this break off is earlier. Why is this break off important? Because when we start practicing anywhere with an entrepreneurship, this break off, if delayed more than 4 or 5 years, actually this center is going to close. But for the rural areas, this break off is quite earlier, even before 1 year. It is possible not only to maintain, but to have a sound profit. This is again taken from an investing banking chart. From junior consultant to senior consultant, rural takes less time. And if you want to be a medical director of an institute, yes, rural is the area. It takes almost 10 years and almost doubles up in the urban areas. What is the disadvantages of rural healthcare? The problem of a king. Because you are 1-in-1 in rural healthcare, you cannot expect more, have to have more than 10 doctors or 10 ophthalmologists having at your center. You cannot have. So whatever problem comes to you, do not have an umbrella for you. You do not have much of consultation to do with some seniors. So we have to deal with all the problems. It can be legal, it can be medico-legal, it can be medical. There can be stereotyping, cataract, again cataract. So it can be stereotype. Chances of professional disconnect. If I am in an urban city, I have so many centers, I have so many doctors to compete with. So I have to be on my toes. I have to be updated every day and night. But that doesn't mean in the rural areas, even with a lesser educational updation, I can have a sufficient amount of earning. So the professional disconnect can happen or may happen in the rural areas or rural practice. There can be political interference. In a corporate kind of a practice, in an urban practice, in a district practice or an institutional practice, where I am not the owner, this political interference usually dealt with the administrative level. It may reach us, but not in that magnanimous way. It can be an uncertain terrain in the rural areas. Centers tend to fail. We see so many centers being closed if you open up the RSBI charts. And they sometimes work as money siphon. They can be a money laundering. The investor can be a money launderer. So we have to be very careful about that. There can be poor connectivity because lots of journey time is to be wasted. And there are many ophthalmologists, as we know, we actually journey from the metropolitan cities to the tier 2 or tier 3 and come back to the metropolitan cities. And lots of time is wasted if this continue like this hybrid model. But if they shift to the rural, this journey time is less. Now this co-work or agent-based practice, this is again very, very important. I practice in an urban area. So like the previous talk was there. So I can promote myself over the social media platform, over a website, over the normal ways of advertisement. So the patient knows me by the normal ways. But in peripheral areas, the co-work or agents are providing at least 50% of the patient. So patient doesn't come to me with directly knowing me or in the first time, in the first year of my entrepreneurship. They may come after 1 or 2 years, but usually they come through a co-work or agent. So there can be legal hurdles. It's a food for thought, probably another talk. Par case payment is definitely low in the rural areas. This is the best available model as per the some studies go on. This is hub and spoke model. So if we can center our, if we have the main center at Tier 2 or Tier 3 city, these are the drainage areas. So we can have village clinic, which operates 1 to 2 times or more than 2 times a month, and monthly or bi-monthly eye camps. This will actually drain the patients, make them informed about our center and what are the facilities available, so they can come, and this will reduce the dependence over the agents or quacks. One information here, in India, cataract to non-cataract ratio is 1 to 200, whereas in the developed countries, it is 1 to 10. And if you go to rural areas, it is more than 1 to 400. So what is the problem there? So we are actually seeing tip of the iceberg problems in the rural areas. And we are not diagnosing, let alone the posterior cases, not even the all cataract cases. Refractive error is a huge problem there. So we have huge case load in the village clinic. What can be the role of YOC here? I chalk out 3 points. Maintain a database of the YO available for the rural, so that all ophthalmologists are not available. Hand-holding of a startup is possible. Monitoring and regulation is possible. And the slide, what do we like, Mark or Beleno? And what is the income trajectory here? So the rural starts at the lower age, but finally end up somewhere higher after the 5th year. Do we have examples from the other fields? Yes. A Bengaluru hydroponic farm by the IIT couple. It is working very fine. They have right now more than 50 crores of investors' money. Kashmir Jaffran marketing, they are actually making this Jaffran processing down in the village level. LVPI model of telemedicine is a very good model of telemedicine. So we can have a hub and spoke model like this. IITH and DRDO joint venture for artificial limb. They're making the limbs right down from the village level. Entrepreneurs are making the parts of the limb in the village level itself. So let's hear the heart out. We have social duties. Can we deny that? Earning is decent in the rural areas. Lifestyle is compromised. But if we think so, there are schools available. And many of us are from the rural areas. How can we come out from the rural areas? Political interference? Where is it not? Thank you for patient hearing.
Thank you so much, sir. I think it's very motivating for the young ophthalmologist to take that stride to become a rural entrepreneur. For the want of time, we just cut short the discussion for now, and I just want the next speaker to be ready. Dr. Kshitij Aditya is a VR surgeon currently based in Varanasi, and he's starting his own center in his hometown Mao in East Uttar Pradesh. So he's the right candidate to talk on this topic, branching out, the reasons to start your own endeavors. So over.
Hi, am I audible?
Yeah, yes, you are. You can share your screen.
Yeah, is it visible now?
Yeah, it's visible.
Yeah. So, hi everybody. My topic today is branching out, reason to start your own endeavors. Disclaimer, this is a fairly subjective view of the whole scenario, and this experiences and everything may vary from one person to another. So whatever I'm going to say may not apply to everybody in every situation. So let's have a look at the types of ophthalmology career in India. So there is a government medical college job. The type of government colleges I'll consider as a prestige or non-prestige. For example, I'll say prestige colleges are like AIMS and PGI, and let's start like not up to that mark. Then there are non-government institutes, which are again non-prestige or corporate. Then there is private practice, which can be individual or a group practice with a mix of hybrid, as totally independent and with freelancing. So let's go to the government medical college job. The types, as I said, it could be a prestige job or a non-prestige institution. And we routinely considered is the advantage of it being a 9-to-5 job. But in a prestige institution, it's rarely 9 to 5 because there are other works. You're included in other committees and you have a lot of other works which are you are included in. So the work hours tend to extend beyond 9 to 5. So we should be aware of it. Then there is the idea of low stress, but there is a lot of administrative interference in your day-to-day activities apart from your work. So it varies. Again, there is an idea of academic fulfillment, but I must say the academic input and output both are limited or limited to very few institutions, precisely the prestige ones, and majority of the government medical colleges do not stress on the academic activities as much. Surely there is a job security, and the job may suit to different personalities. I would say that in a prestige college, it is good for both static and dynamic individuals. The static who just want to do their work, their routine duties, and just go back home. And the dynamic ones are those who are interested in teaching, in academics. They both flourish. But in the non-prestige colleges, the problem is the dynamics ones don't get to flourish that much because the static ones tend to pull them down due to internal politics and other things. And the non-prestige colleges have a lot of infrastructure hurdles. So coming to the non-government institutes, which are prestige, so there is a high academic output. You work with the best of the best in the class infrastructure, though the monetary incentives are not that much, and there is a moderate to high stress to maintain the quality of care and other extracurricular activities. Growth is very good in certain cases in terms of academics and the international recognition, but monetarily the growth may plateau after a limit. So this COVID pandemic has brought some new perspective about in line with this field, because barring few institutions, a lot of such institutions have resorted to pay cuts, and the doctors have been working, putting themselves in front, taking a lot of risk, and working even more hours than before. But still, they are having to accept the pay cuts. But coming to the non-prestige institutions, that will also include the corporate jobs and private medical colleges jobs. There is a lot of cost cutting in terms of infrastructure. So there will be a huge emphasis on the marketing and the basic exterior show, but there will be a relatively low standards of ophthalmic infrastructure. So even in the best of the chains, you will not get the absolute high-end machines. And then there is obviously the menace of administration, the human resource people, and this the demon of conversion ratios, which you are expected to be at par of. And then there is the objectification of doctor as a dispensable commodity. If you will not work, somebody will else work. And if your pay brackets exceed some certain level, then they can always get somebody who will work at your place for like half a pay scale. Then there is one major issue that I want to highlight, that in these setups, we are hired as consultants, but we are expected to behave and work as an employee, while we are not getting employee benefits. Say, for example, we are not getting a comprehensive insurance, we are not getting a, a, a paid CL, EL, those kind of benefits which an employee should get. But we are required to put in the fixed amount of hours, punch in at that time, punch out at that time. So we are expected to work as an employee, but we are hired only as a consultant. So we are not getting the employee benefit part. And most of these places, the academic output is low, but there are definitely exceptions. And according to as far as the COVID goes, even I have heard a lot of my colleagues have experienced pay cuts and even layoffs. Now coming to private practice, there are pros and there are cons. After initial hurdles, initial investments, the monetary rewards are quite high. You get a certain status in the local community, recognition which is not there in the other corporate jobs or private medical jobs. There is a sense of independence, but obviously you are restrained to by your financials and other things. It may cater to a surgeon persona to an extent. We should also acknowledge the surgeon needs to be rewarded uh, physically and psychologically as well. And there is autonomy to charity. If you want to do a patient free of charge in any other setup, you may have to go through a long procedure and hurdle. So in a private practice, you can do that certainly. You can prioritize your life choices. You can choose your workload. You can take vacations. Definitely not earlier in your career, but definitely afterwards. Private practice, the cons are there is a high stress. Apart from the work, you have to take care of the financials, the administration of the hospital, the staff salaries, the staff leaves, and everything. You have to oversee everything, and then there are legal hurdles. There is a business perspective of medicine which we are not very aware of in early of our career, not we are taught about it. Then we have to learn these things on the job. For initial 2-3 years, you don't get time off for yourself or your family, and then there is this aspect of money trap. So there are certain gray areas that you may have to indulge in private practice. A good practice is a good option. It is easiest to establish, but difficult to execute in the long term. So I would just summarize it as this thing, that a job is a means to an end. Whatever you do, it does not encompasses or define you as a person as a whole. There are other aspects of your life which should be taken care of as well. So you should know yourself, plan it out, know your background, and that's it from me. Thank you. And this is the center I'm putting in next 2 months. So let's see how it goes. I'll share my experience in future talks. Thank you.
Thank you so much, Dr. Kshitij, and thanks for everyone. We quickly move to the next speaker, Dr. Rohit Modi. He's a practicing VR specialist from Mumbai. His specific area of interest is disease reversal through plant-based diet. And he's going to talk on a very underrated and very unexplored link between ophthalmology and nutrition. So over to you, sir.
Am I audible and my slides seen?
Yes, sir. Yes, perfect.
Yeah, thank you. So thanks YOSI and AIOS for the wonderful opportunity. Again, I would like to thank these people who have influenced me a lot in my journey in nutrition. Now, what made me get interested in nutrition? I got a 57-year-old gentleman who had uncontrolled DM and had come with bilateral macular edema and with the PDI. He got multiple intravitreal injections over a period of a few months for diabetic macular edema and underwent PRP. Now, when we look at the literature, we know that there is a high risk of acute myocardial infarction and cerebrovascular accident in patients who have DME. The risk is significantly high as compared to patients who do not have diabetic retinopathy. It is nearly 3 times. And over a period of few years, this patient was sincere. He would follow up regularly with me. He underwent coronary artery bypass grafting. He underwent renal transplant. And there's another patient, a 36-year-old gentleman who had come with the bilateral macular edema, severe NPDR. He was undergoing dialysis every other day. He had his 2 toes amputated because of the gangrene, and recently he underwent diabetic retinopathy also in one of the eyes. He was lost to follow, so the disease had progressed. Another cousin of mine who is in early 20s, morbidly obese, came with style. I just got his random blood sugar, it was 368, and on further investigation, he had protein. So there was something which is a missing link. I am treating these patients with respect to the eye, but am I just an eye doctor? Can I do more for my patients? Because I know that they are going to progress to something which is going to negatively hamper their whole lifestyle. Disclaimer, I'm not a dietitian or a nutritionist. I'm still exploring the whole field and there's no financial interest. So I came across this wonderful paper by Bernard et al., which was published way back in 2005. It was an NIH grant study where he compared a low-fat vegan diet, that is a low-fat plant-based diet, to a conventional American Diabetic Association recommended diet. And he found out that, within the 74-week period, there was a greater weight loss in the low-fat vegan group, significant glycosylated hemoglobin changes as compared to the American Diabetic Association recommended diet, lesser cholesterol levels, much lesser, and for coronary artery disease reduces significantly. Now, what was the participants asked to do? Avoid animal products such as dairy and meat, avoid processed foods and added oils, favor low glycemic index such as beans and green vegetables, increase dietary fiber and complex carbohydrate. Now, this is very important. Once we increase this dietary fiber, the absorption of fat and carbohydrates reduces significantly, and reduce total and saturated fat. That was very important. Mind you, portion sizes were not restricted. That is the most amazing thing when you go for a whole food plant-based diet. You do not need to basically curtail your portion sizes. Your appetite itself will auto-regulate to control the portion sizes. And this are the three things which are very important: eliminate animal products, eliminate processed foods, and focusing on consuming plant-based diet. This concept is highlighted even in Physicians Committee for Responsible Medicine Power Plate. If we take a good combination of all of these, almost all nutrients are we are able to take in, except vitamin B12 and vitamin D3. Vitamin D3 is a sunshine vitamin, and vitamin B12 is produced by bacteria. So they are as such not originally present in animal sources. Now, this is an interesting case. When I was exploring this field last year, this gentleman, came with I ended up advising him anti-VEGF injection. For some personal reason, he said he is not willing to undergo intraocular injection. So I handed him out a meal plan, which we usually do for all our patients. I told him, if you're not doing anything for the eye, let us just put you on this kind of a diet. And during that same time, I had come across a paper in which they had actually shown reversal of pulmonary hypertension, diabetes, and retinopathy reversal also, or adaptation of this kind of a diet. And we all know that hyperglycemia is a major cause of all the microvascular and macrovascular complications, which increases the reactive oxygen species. Ultimately leads to low-grade inflammation and endothelial cell damage, which ultimately leads to retinopathy and macular edema. One of the key components, which when we have raw salads, especially raw green leafy vegetables, is that they have high contents of sulforane, and these are very, very effective antioxidants. They have anti-inflammatory action. They reduce the oxidative stress. Many pharmaceutical companies are trying to extract that to make it into a supplement. Why not get it from the original source itself? And the one which we recommended to our previous patient was a combination of green leafy vegetables, flaxseed powder. Flaxseed provides unprocessed oil, fat, which helps in absorption of carotenoids from these green leafy vegetables, and also a fruit to add to the flavor. And bingo, 1.5 months later, surprisingly to me, the edema was gone. Though still in my practice, I do advise anti-VEGF. That is the mainstay of treatment for diabetic macular edema patients and other patients. But I do believe that nutrition has a very big adjunct role to play. Well, when we look at the data from...
but the time is up for this session. We have to move on to the next session. I'm really sorry for this. because we have the next session starting at
Yeah.
11:30. We have already exited like 4 minutes of the session.
Sure.
Really sorry, we have to stop the session here.
Sure.
Yeah, just
Yeah, no problem. Thank you.
Yeah, sorry, I'm really sorry for this.
Yeah, no problem. So, thank you for the opportunity to everyone. Thank you.
Thank you so much. I thank all the moderators, speakers, and the chairperson for this session. Thank you so much for being with us. Stay safe.
Thank you so much.
Yeah.
Thank you, sir.